Okay. Good afternoon, and thank you for being here. We're excited to share with you our Capstone project, Project POTS, tackling postural orthostatic tachycardia syndrome as a wicked problem in primary care. I know that's a lot, but uh, this is our wonderful team who made the project possible. Firstly, we have our PAC and project supervisors who you already heard a little bit about, plus Joseph, who you didn't hear much about yet. Then there's Asnia, an internal medicine resident at Western. She brought the charisma and scientific prowess to our project. Linette, who is really the heart of the team, she's a family physician by training and a stakeholder in the dysautonomia community. She kept our project on track and made sure we were impactful to patients. Then there's Vedant. He's a pharmacist by training, but now he's living in the startup world, and he brought that startup workhorse mindset, keeping our project agile and iterative. Then there's me. I made sure we aimed high and kept our project human-centered. Now that you know a little bit about us, let me set the scene. So it's 9:15 on a Tuesday morning, and Dr. Wright is just starting their clinical list when a new patient walks in. 26-year-old Mary, a former varsity athlete, now pale and clutching her water bottle. Mary describes months of dizziness, palpitation, difficulty concentrating, and crushing fatigue. She's seen 3 other doctors. Her blood work is normal, her ECG is fine, and she's been told it's just anxiety. Today, Mary says she can't stand for more than a few minutes at a time without feeling faint. Dr. Wright listens carefully, but the picture isn't fitting neatly into their training. They recall hearing about POTS, maybe in a podcast, maybe during residency, but they've never diagnosed it on their own. Where should they even look up the guidelines? What tests should they do? And if the diagnosis goes right, who should manage this? One of the physicians we interviewed put it plainly: I don't recall knowing what to do with these patients. Another said, I'm sure we're missing guidelines for initial assessment and first-line management. This is the reality we've heard echoed by physicians across Canada. Diagnosis and management of POTS does not feel straightforward. Long wait times, fragmented pathways, and inconsistent knowledge mean that patients like Mary can go years without answers, and physicians like Dr. Wright are left without the tools or the confidence to help. So, Lynette, what exactly is POTS and how do you diagnose it?
Thanks, Mikhail. So POTS, or postural orthostatic tachycardia syndrome, is a condition where the autonomic nervous system doesn't adjust properly when a person stands. Instead of keeping things steady, the heart rate shoots up by 30 beats per minute or more in adults, 40 or more in teens, without a significant drop in blood pressure. Patients feel lightheaded, get headaches, heart palpitations, and find it hard to concentrate. Because these symptoms can overlap with other conditions, diagnosis relies on objective testing and reference to defined criteria. A simple first check is the active stand test. You have the patient lie down for 5 to 10 minutes to get a baseline heart rate and blood pressure. Then ask them to stand and measure again at 1, 3, 5, and 8 minutes. A positive result is when the heart rate jumps above that threshold and stays there. And that's it. A test that doesn't need fancy equipment, just a blood pressure cuff, a heart rate monitor, and a reference to the defined criteria, and it might give you the answer your patient has been waiting for. We use the Toronto Translational Thinking Framework to guide our process. The framework helps move our research into practice by progressing through 6 steps. You will see them unfold as we go. But the first, and our starting point, was to explore the problem space and identify the issue. For us, the problem was clear. POTS often leaves Canadians waiting years for answers. In primary care, many providers don't have the tools or training to recognize it, leading to dismissal, misdiagnosis, and needless suffering. Our review of the literature and informal sources revealed a clear disconnect between the experiences of patients with POTS and the realities faced by physicians. From the patient perspective, common themes include feeling misunderstood, facing long diagnostic delays, and being mislabeled with anxiety or stress-related conditions. Many describe years of functional impairment and repeated unproductive medical visits. From the physician perspective, many report unfamiliarity with POTS and uncertainty around its diagnostic criteria, which creates a gap between patient needs and clinical readiness. We sought to recognize unmet needs on both sides of the consultation. Physicians need more awareness. They need practical, evidence-based tools for use in clinic, clear referral pathways, clarity on which specialists can help, and confidence in managing POTS within primary care. Patients, meanwhile, need validation of their experiences, early recognition of condition, and coordinated care to lessen the personal, social, and economic toll of delayed diagnosis. These gaps and the consequences they create shaped our research. Our research is grounded in the practical concern that even though diagnostic criteria and treatment algorithms for POTS exist, they are not translating into earlier recognition and care in primary care. This gap is compounded by the lack of research on the experiences of Canadian family physicians in diagnosing and managing POTS. So we asked, what are the barriers and facilitators to POTS care at the level of the primary care physician in Canada? And what can we do to improve this? Our aim is to move beyond identifying challenges to producing translatable insights that can improve diagnosis and equip family physicians to deliver timely, effective care.
To explore these barriers and facilitators and contextualize POTS in primary care, we conducted a qualitative study using semi-structured interviews with licensed family physicians across Canada. We selected this method because it allowed us to explore the nuance, uncertainty, and complexity of how physicians approach unfamiliar and poorly understood conditions like POTS. Our interview guide was co-developed by our interdisciplinary team, incorporating feedback from clinical, methodological, and patient expertise. We also took courses in qualitative methods to help us better understand the theories and approaches to research like this. Our questions focused on 5 core domains: physician knowledge, diagnostic processes, management strategies, referral patterns, and broader systematic barriers. Interviews were conducted via Zoom and audio recorded, transcribed, and de-identified. Each participant was provided informed consent, and we offered a small honorarium to recognize their time and insights. At first, most of our responses came from Ontario, where we had existing contacts. But our research question was Canada-wide, so we used 2 different approaches. First, we worked with primary care research networks across Canada to promote our study. Second, we directly contacted individual physicians and clinics nationwide. We included people in our study who were actively licensed to practice family care within their province. We verified each physician's license number on college websites prior to confirming interviews. Proficiency in English was also necessary because our interview was done in English. In total, we identified 796 contacts. This is both individuals and organizations from publicly available sources. We reached out to 455 of those by email and completed 19 interviews over 2 months.
Our sample included physicians from 8 provinces with a wide range of experience, from those in the first year of practice to those with over 4 decades. Most participants were females, and majority practiced in urban settings and following various billing models. We also did include 2 rural physicians. One of the clearest patterns we observed was inconsistency in physician awareness and management practices related to POTS. Nearly all participants were familiar with the diagnostic criteria. 11 of them were using orthostatic protocols already, and several told us that they first learned about POTS directly from their patients. Every physician in our study referred suspected POTS cases to a specialist, but almost none felt confident initiating management themselves. Only 7 out of the 19 were aware of the Canadian Cardiovascular Society 2020 position statement on POTS, despite it being the only national guidance document on the topic. This limited awareness contributed to uncertainty about roles and responsibilities in primary care. Some physicians recommended lifestyle modifications like increasing fluids and salts, but very few reported starting medications citing discomfort with managing POTS or fear due to lack of insights from specialists. Overall, what this tells us is that while recognition of POTS is improving, Most physicians still feel underprepared to act, and without clear awareness of existing guidelines, many fall back on referral as the default. After coding the interview transcripts in NVivo using a hybrid inductive-deductive approach, we identified 5 overarching themes that captured both the barriers and facilitators to initiating POTS care in primary care. The first theme was systematic barriers in navigation. Physicians describe fragmented system with long referral delays, lack of centralized pathways, and challenges coordinating with specialists. Many simply didn't know where to send patients or how to follow up. Next was physician knowledge and education. There was a wide variability in training and awareness. Some had learned about POTS through patients, others had never heard about the CCS position statement on POTS. This knowledge gap directly influenced their confidence in managing POTS. A third theme related to attitudes and perceptions. Some physicians expressed skepticism about the diagnosis itself or framed it as a diagnosis of exclusion. Others noted internal bias or the fear of missing something else, which shaped their referral behavior. We also saw critical insights around patient-provider dynamics, such as trust, communication, and clinical uncertainty, which all played a role. For example, physicians often relied on how convincing a patient seemed, which raised concerns about equitable care. Finally, we identified a cluster of facilitators and resources. These included access to diagnostic tools, collaboration with knowledgeable peers, and even practical workarounds, like using orthostatic vitals creatively or asking patients to log symptoms at home. Using Blair's iterative coding model, we refined our codebook into 7 categories of barriers and facilitators, adding diagnostic challenges and referral rationale to it. Together, these themes helped us map out the landscape of primary care decision-making for POTS, and not just what physicians know, but how they think, feel, and act when faced with diagnostic ambiguity.
So, having consolidated the results from our interviews, we moved to the next phase of the TTF framework, which was ideation. We needed a structured way to determine which barriers were both feasible to address and most impactful, while also probing the root causes beneath them. So we conducted a root cause analysis using an approach called the 5 whys. We looked at each barrier and facilitator and that we had identified and asked a series of whys to understand how we could address them. So here's one example of the process with one barrier from our study, knowledge and education gap. This was inspired by something one of the physician participants said. I don't recall anybody ever giving even one lecture on POTS. So for this barrier, we started with lack of formal POTS training, undergraduate, postgraduate, and CME training, and ended with lack of widely adopted POTS guidelines. Now, having studied the POTS space for the past 2 years, we have realized that it is a wicked problem, which is defined as a problem which is ill-formulated, where the information is confusing, where there are many clients and decision makers with conflicting values, and where the ramifications in the whole system are thoroughly confusing. Richard Buchanan, who's a well-known design expert, has described the characteristics of a wicked problem, which you see on the slide here. Wicked problems like POTS are multifaceted, and multifaceted problems demand multifaceted solutions. And this is what we explored in the ideation phase. So having generated potential solutions, the next stage of the Toronto Translational Framework is translate design. At this stage, the goal is not yet to pilot at scale, but to design how we would evaluate the feasibility and impact of our ideas. This meant asking things like, how could these concepts work in the realities of primary care in Canada? What outcomes would matter the most, and what feedback loops are needed to refine them? This stage basically lays the foundation for moving forward to prototyping, where we began to develop and test some concrete solutions. So on this slide, what you see is a fishbone diagram that maps our prototypes, and each bone represents a different avenue that we've explored. Because of the wicked nature of the problem, there isn't one single solution. Tackling it from only one angle risks adding more complexity, and that's why we developed multiple prototypes to address different parts of the problem. This visual helps show how our interventions link back to the root causes that we identified. A key barrier we found was time. Physicians aren't compensated for the longer active stand test if they have to do it in their clinics. Since disease-specific billing codes already exist, we explored what introducing one for POTS could look like in Ontario. And then over the past year, we've participated in the Ted Rogers Echo Discovery Program, where we developed OrthoStat, which is a software as a medical device conceptual prototype designed to streamline POTS diagnosis and improve the active stand process. We also saw that many barriers could be addressed through a Canadian-specific website, a central hub for POTS resources in Canada. I'll just expand on that in the next slide. So this is the prototype of a Canadian-specific website that was designed directly in response to barriers we identified and by discussions with POTS experts across Canada. So there's excellent resources that exist, but they're fragmented, and we wanted to give family physicians a central hub for clear Canadian relevant tools, such as diagnostic criteria, management pathways, referral guidance, and practical solutions, practical resources. Future additions that we're considering is including a CME and peer support. We developed a citizen site map and initial build, which you see here. And the next steps include gathering physician feedback, securing institutional hosting, and testing usability so that the platform can remain current and trusted. This site will also be shared with the study participants in the near future. Then a quick word on limitations. Our sample size and geographical representation were limited in part due to time constraints of our recruitment, which narrowed the perspectives that we could capture. But we also heard from physicians who declined from participation as they had no POTS experience. And then looking ahead towards future directions, that should include broader recruitment and inclusion of other primary care roles, especially allied healthcare professionals. We also see a value in exploring patient-physician dyads to capture both sides of the care experience. And finally, validating emerging interventions through co-design and pilot testing is going to be critical to ensure that the solutions that we're proposing are both practical as well as impactful. This gets us to the final stage of the TTF framework, which is implementing interventions. Implementation of each of these is outside of the scope of our translational project, but it can be done in the near future. And when we've already begun taking the next steps, we've shared our findings with the Canadian Family Physicians, College of Family Physicians of Canada, the CME team, and POTS is now under consideration for their fall 2025 curriculum. We've also connected with developers of the CEP POTS tool, which we share on our resource site. Our study report will be published to inform research and guide practical interventions in the future, just to have like some features to be built upon it. And finally, we will be collaborating with a motivated patient group in Ontario to advocate for a new billing code for POTS.
And that's it. I hope you enjoyed our presentation and learned lots. Please do ask us any questions if you have them, or feel free to reach out to us. But before we go, I wanted to acknowledge all of the wonderful people who helped us along the way. We won't ever forget the help of all the family physicians who participated in the study and generously shared their insights. We also want to thank the faculty mentors we had in the translational research program, whether that be students, alumni, professors, instructors, Kim, Joseph, Edita, Raza, Jordan, Julie, so many names, and our project advisory committee for their wonderful guidance and support throughout this project. Their expertise has been instrumental in shaping both the processes and the outcomes of our Capstone project. Thank you so much.